Good afternoon, everyone. Welcome again to the BPD Family and Consumer Education Webinar Series. Tonight, we're going to be hearing from Dr. Brandon Unruh on the topic of mentalization and trust, a new way of understanding borderline personality disorder. Before we get started, a few logistical announcements as usual. So you should have multiple boxes on your screen. You should see my picture in the upper right-hand corner. You should see the slides in the upper left. We will be taking questions and getting through as many of the questions as we can for tonight's webinar. But they'll all be done anonymously and confidentially. So all of your microphones are muted. But we do want you to type in questions. In the lower right-hand corner of your screen, you'll see the Q&A box. If you've come tonight with a specific question in mind, feel free to type it in right now. We'll get through as many of the questions as we can. And then the lower left-hand corner of your screen has multiple links. So that first link is if you want to register for our December 7th webinar. We're going to be hearing from Dr. Rocco Iannucci, who's going to be speaking with us on borderline personality disorder and substance abuse. And then the next three links are really resources for treatment referrals. So one of the questions we get from so many people is, how can I find a treater in my area? And we have participants really from all over the world. We've had over 23 countries and almost all of the United States represented and throughout Canada. And so unfortunately, we don't have referral resources for all of those locations. But those three links are a good place to start. And then finally, this whole webinar series is funded by a philanthropic gift from a family that's been affected by borderline personality disorder. We're hoping to be able to continue these indefinitely, though. And so if you have found these valuable and are in a position to be able to help support them, you can click on the support link, which is also in that list of web links, and give a gift to help continue these webinars. Any gift, large, small, would be wonderfully appreciated. And so tonight, it's my pleasure to introduce Dr. Brandon Unruh, who is the medical director of the Gunderson residence, and he's also an instructor in psychiatry at Harvard Medical School. And again, he's going to be speaking with us on mentalization and trust. And I will turn the webinar over to Dr. Unruh.
Okay. Hi, everybody. Good evening or good afternoon. So I'm excited to be here. This is always great to be able to talk to families, and I'm going to do my best to inspire your trust by looking directly into the camera rather than looking at my slides, because as you'll see tonight in my presentation, one of the things that we think gets in the way of people making progress in their treatments for borderline personality disorder is an impaired ability to come to trust in sources of new information. So given that most of you, or maybe all of you, have never seen me before, I'm hoping to inspire a bit of trust by at least looking right into the camera. So I'll do my best with that. All right, so one of the other things that I do is I'm the director of the Mentalization-based treatment clinic here at McLean Hospital. And I think that's why I was asked to talk on something related to mentalization and trust. And what I'm going to be talking with you about this evening is a relatively new model for understanding borderline personality disorder. And it really speaks in a different way than some of the other treatments do to some of the obstacles that can happen in treatments that may go on for years and years in some cases. So it's going to require a little bit of talking about research, a little bit of talking about some more esoteric theory, but we're going to start with some basics that I hope you'll all be able to relate to. So we're going to go all the way back down to the basics of what is mentalization. So here's the outline of what I'm going to cover. As I said, we'll start with the basics of what is mentalization. Then we'll talk about the relationship between mentalization, attachment theory, and borderline personality disorder. Then I'll introduce this concept of what we call epistemic mistrust as a hallmark of BPD and this new understanding. And then I'll summarize by sharing some implications for treatment. The last part we probably won't get to, but if there's time in the questions, I may say a bit about the specific approach to treatment that we call MBT. So what is mentalization? Here's the classic thinker pose. This is our favorite pose to strike as we're doing this therapy. But don't glaze over just yet if you've never heard this word mentalization before, because it sounds really jargony and it's not clear exactly what it means. But if you look at the next part of this, you'll see that here's Gandalf, and he's capable of mentalizing. He's a wizard. He's talented in the arts of sorcery, so we might expect he could do whatever this thing is that we call mentalizing. But you know who else can do it is Forrest Gump. So the point here is that as complicated or vague as this thing sounds, mentalizing, it's actually something that we all do so much of the time on an everyday basis, hour to hour in our lives. And it's not dependent on how much intelligence you have. It's a much more basic, bedrock human capacity. So this says that mentalizing is nothing special, as I've already said, and this is just a quotation from the treatment developers, Peter Fonagy and Anthony Bateman in London, who developed this approach. And all they're saying here is that MBT is the least novel therapeutic approach imaginable. It's about this bedrock human capacity to hold mind in mind. And I'm going to give you some examples of what this means. And here they're making the claim that therapists of all theoretical approaches, whether it's DBT, whether it's psychoanalytic treatments for borderline personality disorder, or MBT per se, can benefit from some understanding about how mentalizing may be happening or not happening in their treatments. And they further say that patients, no matter what kind of therapy they're in, may benefit from thinking about these concepts that I'm going to introduce today. So with that preface, here is a thought experiment from a British psychologist, Simon Baron-Cohen. Oh, it's not Borat, if you're thinking that. The British psychologist who has actually developed this thought experiment to simulate the experience of a severely autistic person's approach to the world. And he called it mind blindness. So imagine what your world would be like if you were only aware of physical things, but were blind to the existence of mental things, like thoughts, beliefs, knowledge, desires, intentions, anything that happens inside the mind. Now stretch your imagination to consider what sense you could make of what you see of human behavior. And the idea is that this would actually make the world quite a fearful place. Fortunately, though, this is not actually the situation that most of us are in. So this next slide is a test that's developed to, in a sense, test your ability to mentalize. And I just thought it's such a nice, ordinary example of mentalizing that we all do when we meet someone for the first time. And one of the key sources of information that we use to get inside another person's head is their facial expression. And most of you, if you've been following these webinars, probably know already that people with BPD are particularly sensitive to perceiving critical, harsh, hostile, rejecting minds behind what actually otherwise would be a neutral facial expression. So we're going to play along and do a little bit of this thought experiment together. This is called the Reading the Mind in the Eyes test. And what I want everybody to do is just look at this little strip that you see here, just the eyes, and choose between the four. What feeling or mental state do you think this person has? So make your choice, and you'll see that most people choose friendly. Okay, there's no right answer, by the way, about this, but the most common answer given for people who don't have borderline personality disorder is friendly. Next slide. Same game again. So look at this little eye strip and think what your first impression is about what this person is feeling. Most people say worried. Final one. What's this person feeling? Most people say desire. Now, an interesting side note is that people with borderline personality disorder tend to actually perform better at this test than people without BPD, especially when the faces are less neutral. And some of these faces I've shown you are a little bit clearer than others. Each one is a little bit more strikingly one thing rather than the other things. But when you show more neutral faces is when people with BPD start to separate from other people and their ability to give the most common answer. Next slide. So this really illustrates that we're all doing a little bit of this thing that we call mentalizing all the time, just walking around in the world and looking at each other's facial expressions. So we're not mind-blinded, but we're also not perfect mind readers. We don't have a way to peer directly into people's minds and know without any shadow of a doubt what they're thinking or feeling. And we're especially vulnerable when it comes to how they're thinking and feeling about us. And we're even more vulnerable when we have an increase in the intensity of our emotions. And we're even more vulnerable when we sense some interpersonal threat, some risk that someone's about to pull away, or a relationship's about to end, or intimacy is about to deepen in a relationship. And we know that people with borderline personality disorder are actually much more unstable in their capacity to mentalize, especially in those particular triggering situations where there's high emotional intensity or there's an interpersonal risk or trigger. The good news is that actually we all have this capacity to do this to some degree. The difficulty is that this capacity of mentalizing is only impressionistic. It's only our best inference at the moment. So it's error-prone, it's faulty, it's imperfect. And we have to do this work of mentalizing within a relationship to actually get in the dirt with someone and do the work of sorting out, was I wrong about you? Did you get me wrong? Did I get you wrong? Let's understand how we got to this misunderstanding. And that's the work of mentalizing that we want our patients to be able to get a little bit better at with treatment. So what is mentalizing, just to give you a straightforward definition? Well, the jargony definition is at the top. It says, interpreting the actions of oneself and others as meaningful on the basis of mental states, such as desires, needs, feelings, beliefs, reasons, all these things. A little bit more simpler way to understand it is it's just understanding behavior in terms of a mind behind the behavior. What's happening in our minds and others' minds as we interact with each other in the world. So even more so, stripping away the jargon, we could say that it's attending to mental states. Some people like to say it's holding mind in mind, or keeping a concept of mind in your mind as you relate to yourself or someone else. This next one is the one that our patients really grab a hold of, actually, and seem to take forward in the treatment. Seeing others from the inside and seeing ourselves from the outside. It's got a little bit more of a catchphrase aspect to it. It's a little bit more memorable. Another way we can say it is it's the ability to both think and feel at the same time in a nuanced way about what happens in oneself, in others, and between you and others. And those of you who've been watching these webinars will hear some overlap there with the DBT concept of rational mind versus emotional mind. And you'll hear that actually this is a bedrock capacity that all the treatments that have been developed for BPD are trying to help patients build. But they may not call it as such or be targeting it as such. Okay, so a few last everyday examples of mentalizing. So here's one that I like to use with patients. Many of our borderline patients have such trouble identifying emotions directly, or even making sense of their thoughts directly. Sometimes the easiest thing to do is actually just notice body sensations. So someone might be able to notice, my heart is racing. So to help that person mentalize a little bit more, take it up one higher notch, we would ask something like, well, what do you think might be going on? Might you be feeling something? Is what's happening in your body related to something that's happening in the mind? And if we can get that far with someone, which we usually can, a higher level of mentalizing would be to ask, why might you be feeling that way now? And an even higher level is once a person's identified the feeling, is to ask, and you have a sense of where it's coming from, is to ask, well, how are you going to respond to this? What do you do with this? Where does this leave you now? And an even further level might be to look at how do you decide how to respond to this experience in yourself? That's a higher level of mentalizing. One last everyday example I'll give is let's say that you're having coffee with a friend that you've known for years. And you're at a coffee shop somewhere, and all of a sudden this person you think you know really well looks out the window, suddenly, goes quiet, and suddenly you see tears start to come down their cheek. Now all of us in that situation would suddenly be mapping out in our own mind a list of the possible things that could be happening for that person. But we can't be sure until we start to ask questions, until we start to compare our hypotheses with what we know of the person and what we knew of them yesterday and how we knew of them 10 years ago. and what they say when we ask them about it. So all of this is just to hopefully convince you that this mentalizing thing, although it's a fancy word, it's something that actually we're all doing all the time in ways that are more sophisticated or less. Okay, quick slide to show that there's some close conceptual cousins to mentalizing, and this is a paper from a previous participant in this webinar, two of them actually, John Gunderson and Lois Choi Kane, put this beautiful paper out comparing mentalizing to these other related concepts. And people usually ask me, well, is this just empathy? Or is this the same thing as mindfulness? And if you're interested, you can dig up this paper, but it includes aspects of both, but is distinct from them. So we would say that empathy is kind of one half of mentalizing, the part that has to do with others rather than self. But it involves the self insofar as what one is feeling in the moment in oneself is a bit of the link to what someone else is feeling. So it incorporates this concept of empathy, but mentalizing also has an element of understanding the self better. So it's both self and other, whereas empathy is other-directed in a way. Mindfulness is about bringing a certain kind of attentiveness or awareness to those bits of reality that we can be directly in contact with without judgment. The parts of reality we can kind of apprehend directly. But mentalizing includes not just being aware of those parts, but also making sense of those bits of reality we can't just apprehend directly, and most importantly, other people's minds. So when people teach about mindfulness, they usually make the point, you can't be directly mindful to another person's mind. You can only be mindful about your own thoughts, feelings, action urges, body sensations, and you can be mindful of the behavior of other people or your own. But you can't be mindful directly to another mind in that formal sense, whereas we would say you can and need to mentalize other people's minds. So you can get a sense about how these are related cousins, but not quite the same thing that we're going after in this approach. Skip this. And the next one. Okay. So we're getting a little bit research heavy here, so bear with me. I'll try to make this simple and understandable. So mentalizing, as I've already said, is somewhat state-based. It depends on the level of emotional arousal or the level of emotional intensity that one has in the moment. And if you forget about the vertical axis on this slide, just look down at the horizontal axis, which says the level of arousal or emotional stress. And if you start all the way on the left side, you see the purple line reflects the prefrontal cortex and related parts of the brain that are responsible for good mentalizing, the most sophisticated kinds of thinking and feeling that we can do about ourselves and others. This is a biologically based system. So you need certain parts of the brain to be activated in order to be able to do this in the first place. So if you look at the graph now, what you see is that if you're all the way down at 0, all the way on the left side, in terms of your stress level, you're not likely to be able to mentalize very well. So the concept I usually use with patients is if you go on a date with someone that you've only just seen a picture of online and had a lot of fantasies and attraction towards, but you show up and actually discover the person actually is nothing like their picture, they're nothing like their profile, you suddenly just feel really disconnected. You're not that interested or curious. If you sit down and have a 2-hour-long conversation with them over dinner, you're not likely to be actually mentalizing them very well. You're just kind of checked out. You're not so curious or interested. You've already decided there's no emotional activation. So we need a little bit of healthy emotional activation or stress just to be able to mentalize at all. And if there's not enough of that stress in a treatment, then MBT would call it pretend mode. And I'll say more about this, but basically this is a mode in which we think a fair number of treatments land in and kind of get stuck in. It's like the graveyard for long-term, indefinite treatments for borderline personality disorder, where it looks like at one level there's a lot happening, there's a lot of talk in the treatment, maybe the person's using a lot of jargon and the therapist and the patient feel like at times they're in sync, but actually it's not translating into any change. We would say in MBT, maybe one of the things that's going on is there's not actually sufficient emotional stress or challenge in the treatment. So we need to have a certain level of that. As we push further to the right in this graph, you see that the purple line goes up. And those parts of the brain, the prefrontal cortex, responsible for good mentalizing, get activated and come online. But here's the problem. If you go too far over to the right, you push the emotional intensity in the situation too far, the purple line shuts down, and the orange line starts to get activated. And these are the more reptilian parts of the brain, the evolutionarily older parts of the brain, like the amygdala, the fear circuits. These parts of the brain get hyperactivated, the prefrontal cortex shuts down, and as a result, actually what you see are these more primitive kinds of mentalizing. And these represent some of the other problems that we see, which I'll show you more examples of as we go. So the idea is that for all of us to be doing good mentalizing, we have to be somewhere in the middle of this graph, somewhere towards the top of the purple line. We can't have too little emotional stress or too much. And we can kind of err in either direction. Okay, next slide. Next. Okay. Now, this is a really busy slide. I'm not going to read you all the text, but just to share a little bit with you about how we, as mentalizing therapists, assess the quality of someone's mentalizing when they come to treatment. So we tend to ask open-ended questions and listen to the answers, and these are the key areas that we tend to ask about. Sense of self, things like how would you describe yourself as a person? Very open-ended. How would someone else describe you? What makes you an individual? How have you changed over time since you were a child? How have you not changed? You get a sense. These are very general questions, but in listening to the answers, we can get a sense about how well someone can mentalize, and I'll show you a little bit what we look at in a minute. The other areas are we talk to them about past and current relationships that are key, and we want to know something about how those relationships have stayed the same, how they've changed over time, what sort of person is the patient in each of these different settings, who do they have that they feel loves them or understands them. We also look at major stressors from the past, any major losses or examples of abuse or traumatic situations. And then, of course, we're going to take a look at the behaviors that may be bringing them into treatment, like self-harm or impulsivity or emotional instability. We want to actually ask in a very open-ended way about how these behaviors represent solutions, how they feel about them. Is there ever any other way that they're able to help themselves? These kinds of general questions. So it sounds very much like a general psychiatric intake for treatment. But the way that we're assessing the answers is a little bit different, and I'll show you that on the next slide. So we have, roughly speaking, these three compasses that we use. And I share these with you because I think this is a way to better understand where you yourself may fall into not so good mentalizing and where you're able to do it well. I think that if we can appreciate our own weaknesses in mentalizing as clinicians and family members, we're better able to appreciate the difficulties our patients have. So we're going to go through each of these briefly. So next slide. The first thing we look for are general signs of good mentalizing. So just to show you some of the things that we regard as evidence that someone's mentalizing well, is that they treat other minds as though they're opaque. But they're not completely mind-blinded like we showed you with the thought experiment at the beginning. They're able to make some educated guesses, but they don't see themselves as mind readers. So they treat other people's minds as well as their own with a little bit of uncertainty. That's the sign of healthy mentalizing. We look for the absence of paranoia. We look for somebody generally able to be reflective about themselves and others. Can they look at the same situation from different perspectives? And we look for this quality of interest and curiosity. Or instead, is the person so uninterested and uncurious about other people that we're going to really have a hard time in treatment unless we're able to find ways to help the person get interested in taking a second look at themselves or others. Is a person able to forgive? If you think about forgiveness, that's based on looking more deeply past someone's behavior into their mind. And that's particularly hard to do when someone's hurt you. So the quality, the capacity to be able to forgive self and others is a sign of good mentalizing. And here's a few more. Does the person perceive that their own mind has changed over time? Can they trace out some of the ways that their understanding of themselves has deepened, or do they feel like they don't understand themselves any better now than they did when they were 12 years old? Can they be a little bit skeptical about their own mind and whether it should be trusted all the time? Because we all know if we search ourselves, there are layers to our own minds. We don't always have full conscious awareness of why we do everything that we do. So is there a little bit of healthy skepticism about the trustworthiness of one's own mind without further reflection? We'll keep going, I think, just to show you some of the things that we're looking at. Then there are a few signs of not so great mentalizing that we look at. And we're not so concerned about using these judgmental words, good or bad, as the DBT folks are. We're okay with it because in MBT we know that we're always actually making judgments and appraising things in a very rough way. The mentalizing response is to use the first impression and then look more deeply beyond it to see what else is there. So if someone uses excessive detail or concreteness in describing themselves or an interaction that was challenging, but don't speculate about the motivations or the feelings or the thinking that was underneath the behavior. If someone is extremely preoccupied with rules and responsibilities or gives these moralizing answers about should or shouldn't, it reflects a difficulty to actually look at what is for the person rather than fall back on these more scripted kind of social mores or moral rules. Is the person able to see themselves as responsible and contributing to misunderstandings? Because most misunderstandings are transactional. They require a contribution from both sides rather than blaming or labeling. We'll keep going. Okay. So here's a quick example from the adult attachment interview. This is a standard question that gets asked. This is the most formal way of assessing a person's attachment style. So the question is, why do you think your parents behaved as they did during your childhood? And here's the answer. And you think about, based on what I've said, do you think this is basically good or basically not so great mentalizing? So the answer is because I think perhaps I was a very demanding child that needed a lot of attention. My mother, for whatever reason, wasn't able to give me that attention. And I don't know for sure, but I suppose we were quite naughty as children. Or to her, we appeared to be naughty. And therefore, she was constantly having to chastise us. Okay, now compare that to what comes next. How the hell should I know? Go and ask them. You're the bloody psychiatrist. This is British. They've just always been terrible parents. So if you compare those two answers, you can hear that in the first one, there's some uncertainty. He or she says, well, we were naughty, but maybe it was more that we appeared to be naughty and weren't actually in fact. And there's a little bit of a movement from considering self to also considering others. You know, the perspective of the mother and what the mother might have understood about the behavior. So there's a little bit more fluidity, a little bit more flexibility in the system there. And in the second answer, it's pretty black and white. Person is sort of offended just to be asking, is really not that curious, and is very overly certain about the answer. So these are just some examples. So the second thing that we look at when we're assessing mentalizing is whether or not a person can fluidly move across these different polarities. And again, we like polarities in treatments for borderline personality disorder. This is a lot like DBT in some ways, rational mind versus emotional mind. But we add our own polarities in mentalizing treatments. And so you see, we're going to disregard the first one because it's really partly for research purposes. But is the person able to have an understanding of self as well as an appreciation of what's going on for others at the same time? Is the person able to look at the behaviors or the external, the visible parts of an interaction while also imagining what's going on behind the exterior, what's going on behind the facial expression or the tone of voice? Is the person able to think at the same time as they feel and talk about and integrate both aspects of experiencing at the same time? And are they overly certain or able to also have a healthy amount of doubt? Or are they overly lost in doubt and feel that no one is trustworthy and nothing is certain about their own minds or others? And then we look for this particularly as the treatment gets going. Is the person able to move between emotional closeness and emotional distance, both with the clinician in the room and also with other people in their lives? So we look at how people move across these polarities or don't move across these polarities. This is a slide that looks this is a slide that looked a little bit complicated, back one, but it highlights for you how when mentalizing goes offline, according to this model, it results in particular failures of mentalizing that then themselves downstream contribute to the development of the symptoms of borderline personality disorder. And you see these at the bottom, the interpersonal instability, the self-harming behaviors, the affective instability, and so forth. So let's go quickly through each of these three non-mentalizing modes. And the jargon here is kind of fun if you're a person who likes fancy words, but it's really not that important. What I want you to get is just a general sense of the experience. And some of you may immediately recognize these in your loved one. But the reality is we actually all sometimes fall into these modes, so we should be able to recognize them ourselves as well. So the first one is psychic equivalence, and the image I like to use for that is the judge bangs the gavel. The idea is something is the way that I think or feel it is, just because. It is that way just because. And there's no ifs, ands, or buts about it. End of discussion. The verdict is in. No evidence to the contrary is going to shake this position, how I feel or how I think about it. Okay, so that's psychic equivalence. Next one. Next slide. An example of psychic equivalence, by the way, would be, just happened to me the other day, a patient comes in and just within the first few minutes, she says to me, "You're mad. I know it." And I'm actually, in that moment, completely unaware of any angry feelings toward the person, but she was absolutely certain about it, and we went on to explore a little bit what was making her so certain about it. But that was an example of psychic equivalence. I really couldn't see it in myself. When I actually told her, I'm not aware of that in myself at all, I don't see it, you're going to have to explain where you're getting this from. It was not, her belief that I was angry at her was not changeable. It was not very responsive to me trying to tell her I wasn't angry at her. What it was responsive to was me trying to actually assume that there was something valid, something she'd seen that made me think that I was angry with her, and getting really interested and curious about what she'd seen that I was missing about the interaction. And it turned out there was actually quite a lot that I was doing that when she explained it would naturally make someone think someone else was angry with them. So it made a lot more sense, and the way in to get around the psychic equivalence was to express a lot of curiosity and interest. And those are some of the hallmarks of a basic mentalizing stance that we as clinicians take and that we ask patients to take in this treatment. So the next example of non-mentalizing is another fun word to say, teleological mode. And this is it's a mode of experiencing in which the only way you know how a person thinks or feels about you is based simply on how they act, based simply on what they do or don't do. So my favorite example is John Cusack from the movie Say Anything, one of the greatest 80s romance films from John Hughes. And here he is making this bold, dramatic gesture, proclaiming his love. And it's not enough just to say that he loves her, but he's got to drive outside to the house. He's got to actually, blast the Peter Gabriel song. It's got to be big and bold for it to mean something. The other example here is somebody who's been hammer texting, maybe a partner or a friend, desperately trying to get a hold of them. Maybe he's texted them 100 times in the last hour, and he's getting increasingly worked up because the person hasn't responded yet. And he's assuming that the lack of response means that the person doesn't care about him. Because if they cared, they would have responded immediately. And then the last example is, again, needing to see something in a physical sense in order to believe it. So this is somebody who needs a little bit of self-esteem massaging and who had "I'm awesome" tattooed on their back, but unfortunately there's a typo. So you just need to imagine what was going on in that person's mind that they needed to see it on their own skin in order to feel it. That's teleological mode. So examples of this with patients are when something that you do as a therapist or as a family member gets interpreted as proof that you don't care. And in fact, you're sitting there thinking, that's not it at all, actually. I care a great deal about this person. Another example from a patient is someone appearing for a date in very unglamorous clothing, and that person suddenly deciding in the moment, well, that's just a proof that she's actually not interested in me. This isn't going well. When it turned out the person had just come right from work because the date had been arranged very last minute. Next example. Okay, and lastly we have what I called earlier pretend mode. And this is an experience of emotional disconnection, or a kind of ingenuineness, or lack of emotional clarity or presence in the room. And it's something that does seep into a lot of the longer-term treatments as they play out over time. There's a lot of reasons for why it happens, but as I said before, the general thing that's happening is there's not enough emotional challenge or demand in the current interaction. for someone to be bringing forward into the treatment the really salient and important aspects that they need to be talking about. It's more comfortable to actually talk on the surface about the problem or use a lot of therapy jargon to really talk around the issue rather than deal with it directly. Okay. Next. Okay. So we've talked about mentalization. We've talked about what it is. We've shared a little bit of how we assess it in these treatments. The next section is about mentalization and how it connects to attachment theory and borderline personality disorder. So one slide to summarize all of attachment theory for you. So the basic idea is that we're all born with a predisposition to attach to those who are in a position to take care of us. These are evolutionarily preserved, instinctive behaviors that all of us have when we're born to different degrees that facilitate attachment, by which we just mean an emotional bond of mutual caring and interest. And what we call attachment bids in red there are the things that we do instinctively as babies to reach out to our environment and let them know that we're in distress. We have some need that we can't meet on our own. We need someone in a relationship to come and help us. And these attachment bids naturally get activated when we're distressed, when we have unmet needs. And I'll show you a model for how that works when it all goes well. But we know that in borderline personality disorder, according to this theory, one of the things that creates the symptoms and perpetuates the symptoms over time is actually what we call an insecure attachment style, and a kind of relatedness to one's early attachment environment that actually didn't communicate that the environment is attuned in a certain way to the person. And it results in the inability to regulate and contain one's own emotional experiences, the inability to trust new environments and go out and explore and separate and be less clingy or dependent on one's caretakers, and the inability to sustain meaningful relationships in general. So here's a grid showing what happens when things work well. So we see the infant there in the yellow circle who makes an attachment bid towards the caretaker, maybe crying or something like that. And if this process that we call marked contingent mirroring, which I'll explain next, if that goes well, then it results in an infant having a secure attachment, which involves healthy self-awareness, healthy ability to regulate oneself when one gets scared or angry or ashamed, and what we call a secure base, from which then, as the child grows up, the adult can separate from the caregivers, and that's what we call separation and individuation. You have to have a certain trust in the world that one has gotten from one's earliest attachment relationships in order to be ever able to go out and forage and have new relationships without needing to be overly dependent on the early caregivers. So the concept is that secure attachment facilitates good mentalization, and good mentalization facilitates secure attachment. So these are totally bidirectional processes. So here's another complicated slide. So just walk with me through this. If you start on the lower left side, look at the bubble that's marked child. So this is a baby who has some kind of distress, some physical need that he or she can't yet verbalize. Maybe the diaper is full. Maybe she's hungry. Maybe he's got a splinter in his hand, right? There's some physical pain. And the baby sends what we call an attachment bid, there you see it again in red, to the caregiver. And if all goes well, three things happen in the caregiver's mind that would be what we call good mentalizing of the baby. So the first thing that happens is resonance. The caregiver would have to actually register that the baby is in distress. So if my 2-year-old daughter crawls towards me, or now walks towards me, and starts to cry, I have to register actually that she's in some kind of distress, just in a very basic way. I have to hear the signal. And then I have to go and reflect on what could be the cause. So I start to mentalize and start to generate some hypotheses. Is it the diaper? Is it food? Is she tired? Is she hurt? Etc. But then the part that's crucial is I have to give back some what we call a marked mirroring display. That's the signal I'm going to send back, which is some recognition that I've registered the distress, that I have some idea about the problem, that I'm in the right ballpark, that I'm not laughing at her when she's in distress, something like that, that would be completely non-contingent to her distress. And I also have to communicate that I have her specifically in mind, that I'm not just responding as a textbook, that I'm not just using, if it's with a patient, I'm not just using a therapeutic technique that all the textbooks would outline, that I'm not just doing the same thing with this patient as I would do with the next 10 patients. It has to feel person-specific, tailored to that particular situation and individual. And when that process goes well, we call that marked contingent mirroring, and the result of that is that the baby, or the adult, or the patient, has a sense that actually the initial problem they brought to the caregiver maybe is manageable in the context of a relationship. That maybe this person who's sitting across from me is somewhat trustworthy. That maybe we can work this out differently than I could if I was left to my own devices. Maybe the world isn't such a fearful place after all. That's when it all goes well. Okay, so this slide is something I'll direct you to go see on YouTube. It's the still face experiment. And I'll just briefly explain what it shows. It's copyrighted, so I can't show it to you. But it is available to watch on YouTube. And it's a classic experiment that many of you probably are familiar with. And what it shows is a baby interacting in a very healthy way with his mother. And you see this back and forth affection, this really nice example of mirroring where the mother is responding to the baby's cooing, the baby points, and the mother's gaze turns to follow the pointing. You see this great healthy responsiveness back and forth. And then the researchers cue the mother from behind the window to go still face. And the mother's face goes suddenly non-responsive, and she doesn't do anything to show that she's listening. And you see in this vivid, hard-to-watch detail, the baby's distress suddenly escalate. He points and is distressed when suddenly the environment isn't responding in that person's specific way. And you see that distress escalate. And then the researchers, after a minute or so, cue the mother to now just be herself again. And that marked contingent mirroring responsiveness returns, and you can see immediately the distress is relieved in the baby. So it's just a nice example about where you can watch this marked contingent mirroring when it's there and when it's not there, and just how important it is for all of us as babies coming to learn to regulate our earliest experiences in ourselves. Okay. In borderline personality disorder, we know that the most common attachment style, however, is not actually secure attachment, but insecure attachment. And so the attachment bids in an adult with borderline personality disorder are often described and experienced as more clingy or angry or passive, like silently withdrawing in a way that leaves the environment very concerned about the person, or very oscillatory so that no one can really feel they can make sense of what a person needs or wants, or dissociated, quite emotionally detached, or very controlling. And unfortunately, a natural response to that kind of an attachment bid is that a caregiver responds in kind. This happens to good therapists. It happens to family members. It happens to friends and partners. And the caregiver response is to become more overly involved in a way that undermines the person's agency to figure it out for themselves, overly protective, or just to be inconsistent because one's own emotions are flaring so intensely that your own mentalizing gets impaired. And that same model I showed you at the beginning that applies to not just patients but all of us. Or become downright hostile or aggressive, or extremely overrun with your own anxiety and sense of powerlessness to help the person. And that disorganizing and frightening response unfortunately fuels this vicious cycle in which it really degrades a person's ability to trust anyone in the environment. So it's a vicious cycle that plays out over the course of a person's life. So in the attachment model of where BPD comes from, it's a transaction between these insecure attachment processes happening early in life and throughout adolescence, and the biologically mediated, what we call endophenotypes, things like impulsivity or emotional instability that really aggregate more in families. So we know that they're more biologically driven at the start of life. And the transaction between these two is what over time creates and perpetuates the symptoms of BPD. Skip that. Skip that. Skip. I'm going through these quickly because they all sort of say the same thing. So, there we go. Okay, so this is just saying the same thing this vicious cycle between two family members. So if you start at the left side, family member number one the patient with BPD starts with a level of intense emotion. They have some problem that they come to family member two for help with solving. But because of the emotional intensity, family member one is not mentalizing very well, and therefore is going to have a really hard time appreciating how they may come across. There's going to be a failure to relate to the listener or to empathize with the difficulties the interaction may present on both sides. So they respond in a controlling or disorganizing way. That then in turn actually influences the emotional response of family member number two, whose mentalizing is then taken offline by the emotion, who then in turn is unable to relate or empathize with family member number one, and then responds in kind with another controlling or disorganizing or frightening behavior. So you get the sense of how this just perpetuates itself, and over time really reduces a person's capacity to trust anyone or anything. Next. Keep going through that. Okay. So the next section is about this new understanding that one of the hallmarks of borderline personality disorder is epistemic mistrust. So there are studies that people may be familiar with that have shown that people with BPD have all kinds of difficulties with trusting other people and social systems. So this was a study that showed in a multi-round economic game theory exchange an incapacity to maintain a cooperative stance with other people who you're supposed to be partnering with to win money in this game that's simulated. And as opposed to people without BPD, what we saw in the study was that patients with BPD were unable to maintain a cooperative stance over time. And the theory is that it's really because actually of the expectations that they have about other people not cooperating with them. We also know there's some biological correlates to this. There's parts of the brain known as the insula that don't respond to this challenge to cooperate in the same way as other people do. So studies like this have highlighted that there's these these baseline templates of mistrust that are present in the average person with BPD's mind to start with that contribute to the difficulties we see with trusting and cooperating with others in the larger world. Similarly, studies on oxytocin in borderline personality disorder have shown that people have these pre-existing templates of mistrust from an early age. So it was once thought that giving intranasal oxytocin to people with BPD because they struggle so much with trust and attachment might promote attachment because oxytocin is the attachment hormone, and it promotes attachment and bonding between mothers and newborns. And whereas you do see that happen in people without BPD when you administer this treatment, when they gave oxytocin to people with BPD, it actually decreased their trust, and it decreased the likelihood of cooperation. So it highlights that there's this pre-existing expectation that the world is not a trustworthy place. It's just there at baseline. And the problem is that treatment can easily make these things worse. So that a patient who brings an emotionally challenging problem to a new therapist is going to be feeling some distress about the very act of bringing that problem to a new person. So what happens is, this situation of bringing a problem that's already highly charged to an interaction interpersonally that's going to be even more highly charged because it's a new therapist, leads to intensification of the emotional problem, just as it's being brought to a person who might be able to help. So there's an escalation in the distress, both in the mind of the patient and maybe in the mind of the caregiver as well. There's a hyperactivation of the attachment system, and that further shuts down the capacity to mentalize. So what you see over time is that people who are seeking help with this problem of trust actually end up doing things that exacerbate the problem. And treatments, if they're not carefully attentive to this capacity for trust versus mistrust, actually can make people worse in this very way. Okay. So let's go back, and this will be kind of our final set of concepts, then I'll take some questions. How do we come to trust people and learn about the world in general? So the idea from the latest research on learning theory is that cultural learning is transmitted in one of two ways. We either accept information about the world just on the basis of content, because we think it's logical. We use our logical, rational minds, and we judge that what's being taught to us makes sense. But that's actually not the way we learn most things. The way we learn most things is by deciding that the authority figure who's teaching us the information is trustworthy. We evaluate their trustworthiness. And if you think back to your best teachers in high school, right? The best teachers in high school don't just teach you the body of knowledge, but they teach you something about what it is to be a person in the world. At least that was true for me. So this is Peter Fonagy, who's one of the developers of this theory and of mentalization-based treatment. And the idea is about epistemic trust. Epistemology is the study of how we come to know things. So this is about trust and how we come to know things about ourselves and about the world. And this defines epistemic trust as being about your judgment about how authentic or personally relevant is what a person is trying to teach you. It's a necessary condition for any learning. And for any therapy to work, according to this theory, it has to create a secure attachment. It has to create this epistemic trust in the clinician and in the treatment system or the hospital or the treatment team. A person has to come to believe that these are going to be trustworthy people, trustworthy sources of information about the world. Now, how does this happen? It happens, we know, through what are called ostensive cues. And these are signals that we send, often non-verbally, that what I'm going to say next, I'm looking at the camera directly as I say this, what I'm about to say next is specifically intended just for you. Not for anyone else, it's just for you. And Peter Fonagy likes to show video footage of Bill Clinton at a big rally doing this, because he'll stop the audience and say, now hold on, make sure you're with me here, make sure you're really following, don't tune out. There's a lot of these ostensive cues that he's using, and I think we see some of that in Trump as well, but it has a little different flavor to it. But in infants, it's eye contact that we give them. It's the motherese tone of voice. Oh. It's the mirroring gaze. It's the turn-taking. They do something, then we do something. Then they do something, then we do something back. These are ostensive cues that we all naturally show towards babies. So next slide. I think for the sake of time, I'm going to skip this slide, but what it does is it shows that without these ostensive cues happening, babies don't learn information that they can take into a new context. Briefly, this study shows that when you have these two research assistants, the one in gray and the one in black, if the one in gray comes in and first spends a little bit of time relating just directly to the baby and smiles and says, hi baby, and gives them these ostensive cues, then the baby's able to learn something about what gets taught that they're able to take to the second research assistant and still work with. But if the first research assistant comes in and doesn't do any of that, hello, how are you, hi baby, if it's not personalized, then the baby actually learns the information in that context but isn't able to take it anywhere else. So let's go through this whole slide. So what this tells us is that if this quality of epistemic trust has to be there for people with BPD to learn new things about the world, then it has to be there in our treatments. And the theory is that people over time who don't have this kind of trust in the world, it gets further degraded. And this results in people being called untreatable or treatment resistant or seemingly hard to reach through all the relational channels that we normally would reach each other through. And the idea is that any good therapy for borderline personality disorder has to employ these ostensive cues to ensure that every moment in the treatment, the person, as much as possible, the person has the experience that the treatment system or the therapist specifically has them in mind. So, next slide. Let's go through this quickly. All the way through. Okay. So the idea is that all the different treatments that exist that have been evidence-based for borderline personality disorder may work according to these three systems of learning. And this is, I hope you're still with me through this. I know it's been kind of heavy and very conceptual, but this is the last piece. And the idea is that whether it's DBT or MBT or TFP or any of the other treatments, They may all be doing the same things, just in very different ways. So system one has to be in place for a treatment to work. This is the stuff that's specific to that particular treatment. The information that gets communicated to a person as they're starting treatment about what borderline personality disorder is, how to understand it, particular ways that people can change, what the mechanism of change is, what the goals of treatment are, and then some of the specific aspects of the treatment, like in DBT, it would be teaching skills. We're using that didactic group format where there's a leader with a whiteboard. It's all very structured. So some people with BPD really respond to that and feel that that's speaking to them in a way that feels personal. It's a manner of learning that feels personal to them. But many of you probably also know people who've tried DBT and said, I can't tolerate this. I don't want to be coached. I don't want someone else telling me what to do, and would never set foot into a DBT skills classroom again. So some of these other treatments may present different ostensive cues that may feel more personalized and attuned to the needs of other people. So like in mentalization-based treatment, the treatment that I run in the MBT clinic, it's much more unstructured, and we talk a lot about embracing uncertainty and how none of us can ever really know for sure what the right thing to do is or what's in each other's mind. And some people feel really specifically spoken to by that approach. In TFP, transference-focused psychotherapy, there's a lot of talk about anger, aggression, and integrating parts of the personality and parts of experience that otherwise get split off and aren't brought in. And that conceptual kind of esoteric language appeals to a different kind of person. So that's system one, is that each of the treatments has to sort of appeal to a person in a very personal way. When that happens, we think that it opens up a channel for further learning in the rest of the treatment as the trust develops. And that's system two. We think that through that epistemic trust channel opening up in a treatment, whatever treatment it is, a person gains a capacity to mentalize in a much stabler way. And according to this theory, that's a common factor in all the treatments that leads to improvement. And when it's not there, it's a barrier to improvement. And finally, and I'll end with this and take questions, system three is the idea that it's not actually at the end of the day about what happens in the treatment. If epistemic trust has happened, then a person will be able to take what they've learned in the treatment, what they've come to trust from the therapist and the clinician and the system and the hospital, they'll be able to take it out into the world. Because it's opened up a new manner of learning. Not just taught new information or skills or the ability to mentalize, it's taught someone how to learn. It's opened up these kind of calcified channels of learning that never really developed in the first place. So I hope this gives you a way to think about why some treatments work, why some others don't work, and maybe it gives you a window into some of the difficulties your loved one may be having in their treatments, where they get stuck. I think I'd better end there for the sake of time.
Great. So Dr. Unruh, we've got several...
Let's go to the last slide too, so people can see.
We have got several questions that have come in. So one question, based on the topic that you just mentioned. So if people with BPD have trouble with trust, let's take somebody who really has great difficulty trusting. How do you, and has difficulty getting into a therapeutic relationship as a result? How do you deal with that problem? And what if the therapist has never heard of MBT? And what if the therapist is really having great difficulty getting this person to trust? Let's take somebody who's out in a rural area. You've got a few clinicians to choose from, and none of them seem to be going all that well.
Right. Great question. So hopefully what a clinician would do, you don't have to be formally trained in MBT to do this. MBT is just a specific way of targeting this specific capacity to trust. But like I said just now, we think that all these treatments do this actually roughly equivalently well. What I would do with someone who comes to treatment saying, no treatment's ever worked for me, is to explore the heck out of that. Get really curious and interested. And we don't do anything to challenge any of these impressions to start. We just try to come alongside someone and understand exactly how it is that no treatments have ever been helpful. then MBT has some specific ways of actually working towards introducing some alternate perspectives. And that would take a whole other hour to go over kind of how we do that. But there are some commonsensical ways, strategies that we use around perspective taking, trying to help a person move across those polarities that I showed you at the beginning, and then gradually becoming a little bit more challenging of a person's certainty that a new treatment won't work. We start to challenge the more black and white conclusions that usually become apparent when you listen to someone's sort of woeful stories about why nothing else has worked. So there are some general strategies, and then there are some specific strategies that we'll have to talk about maybe in a follow-up down the road. We can share more with you about how MBT comes at this and share some of the techniques.
Great. So the next question is about somebody who has a daughter, and she will often let this parent know about body sensations, and this parent will notice her facial expression, and we'll try to talk to her and find out, like, what are you feeling, what are you experiencing, and she often just gets, I don't know.
Yeah.
I don't know. Any recommendations for the parent to move beyond this I don't know?
Great. That's a great question. So what's great about that is it's a kind of attachment bit. We would understand it as that. A person's coming to you with some distress. They may not be able to label it. They may not be able to tell you exactly what's going on, but they're coming to you actually. So that suggests that at some level, there's some request for some help. So what do you do or say? Part of what we do in mentalizing approaches is use our own ability to imagine and mentalize what may be going on for the other person. And we just transparently put that out there. So you can say something very ordinary like, yeah, that's really tough to not know what you're feeling. You know, can I just share with you a little bit about what I'm wondering about based on how you look? It looks like actually you've got your hands all balled up and clenched into fists. That might make me wonder if you're angry. And sometimes when I clench my fists, it means that I'm angry. Oh, it's not that? Okay. Well, I also noticed that it looks like you're on the verge of tears, actually. And for me, sometimes that means that I'm sad or about to cry or maybe ashamed about something. I notice it's hard for you to actually hold my gaze as we're talking. It's hard for us to look at each other. You know, might that be feeling ashamed? So it overlaps a lot with validation strategies in DBT, but I think the special emphasis in mentalizing is to say that you use our own mind, our own ordinary mentalizing processes, and we put them out there transparently. We share exactly what we're thinking and feeling, and we hope that the person's able to use that as a stabilizing presence to make more sense of what their own mind is doing.
So, Dr. Unruh, unfortunately, we are out of time tonight, so thank you so much for a really robust presentation on mentalizing and trust. You really presented us with a lot of information, and we may be able to have you back sometime soon to maybe entertain more questions and kind of clinical applications of this. I want to remind all of our viewers that if you want to register for our next webinar, which is currently scheduled for December 7th, we're going to be speaking on borderline personality disorder and substance use disorders. So you can feel free to click on that link right now and register. And with that, I will say good night to everybody. Thanks for